Everyone. This is a real pleasure to do this webinar this evening. I want to thank Pat, Erica, and the Pennsylvania Breast Cancer Coalition for the opportunity to address this very important and really not very well understood topic of breast density. It's timely. We're having this conversation at a time when people are wrestling with what does breast density mean. Pennsylvania is now one of 21 states that has a breast density law. There are, however, important differences among the laws that exist in various states. Many don't provide insurance coverage for additional screening and health care associated with levels of breast density. There's no real solid data at this time that defines risks versus benefits of supplementary screening in this population. And so this is leaving women and their physicians in very uncomfortable positions in many cases. So given the complexity of these circumstances, there is a great need for education, and we're fortunate to have the Pennsylvania Breast Cancer Coalition leading this advocacy. So as women, as we begin to understand more of the implications for our health when it comes to breast density, women should be more empowered to have a more meaningful discussion with your healthcare provider. And I think that we're trying to take another step down that road this evening. So I hope this is meaningful for you. Erica, I can't advance my slides.
Oh. And you've tried both the arrow key and clicking it and it's still not going?
Hang on.
I click not on the black, but in the middle. Yeah, try clicking anywhere in there. There we go.
Okay, got it. So this is a summary basically of what we'll be discussing this evening. We're going to talk about parenchymal breast density, or breast density as a predictor of breast cancer risk. Going to talk about women at highest breast density having a higher risk than women at lowest breast density, and the research that supports this, both the strengths and the weaknesses of the research. The frequency of increased density is greater than other recognized risk factors. Increased breast density is quite common. It's present in 30% of post-menopausal women. But we're not 100% sure what the impact of that is, and we're going to discuss that thoroughly. 10% of women who have breast cancer have positive family histories. 6% of women who have breast cancer have genetic mutations. So I'm trying to put that a little bit in perspective. We also know breast density can be altered with intervention, and we're going to discuss the role of supplemental screening for those women of high breast density. So to start, we have an image of a mammogram here, and you can see that their density basically refers to the whiteness that appears on the mammogram. This is a MLO view. We refer to it as an MLO view, or a mediolateral oblique view, and you can see the pectoralis muscle, that triangular white shadow in the upper right-hand corner of the image. And in the breast, you can see there are varying degrees of whiteness and blackness. And the whiteness is the fibroglandular tissue of the breast. This is the functional portion of the breast. The fibroglandular tissue is made up of both epithelium, which is the duct lining, so that is the cells that specifically line the ducts, and the fibrostroma. The fibrostroma is outside of the glandular portion of the breast. The glandular portion of the breast is most influenced by hormones. The fibrostroma, we're beginning to learn, also has a very important role in breast physiology. So just to take us back in history, Dr. Wolfe originally in 1976 discussed 4 patterns of breast density, and he was the first person to actually give breast density any meaning. He went a little farther than most people would have liked, however. His high breast density was termed DY, and he said it was associated with a 37-time increased risk over the lowest, which was N1. But Dr. Wolf was espousing prophylactic mastectomy for women with DY. Went a little further than what we would think about today, certainly. But he was important because he did recognize the fact that these different patterns of breast density had a masking effect that sometimes precluded the radiologist from seeing the cancer on the mammogram. The problem with Dr. Wolf's patterns were that they were very hard to apply and observer agreement was very poor. But he did put this on the map, parenchymal breast density on the map for decreasing mammographic sensitivity. Along came ACR BI-RADS in 1993, and they did mandate that density information be included in mammogram. And they felt that this is the College of Radiology felt it was important because they knew that the sensitivity of the mammogram was affected by the breast density. It's important to note that this was probably inconsistently applied by radiologists across the country, but as time went on, it became more consistently adopted. The important change now with our state laws is that women are directly told in their letter about their breast density. The ACR BI-RADS simply made it a requirement that the breast density be included in the report. There are 4 categories of breast density according to the BI-RADS, the ACR BI-RADS. And the first you'll see on the left is the fatty breast, primarily dark fatty tissue without a lot of white fibroglandular tissue. On the right we see the second category, which is scattered fibroglandular tissue. And on this slide we have the heterogeneously dense and the extremely dense breast. So you can see as the breast density increases and more whiteness occurs on the film, a small area of whiteness, which is what tumors look like on a mammogram, could easily be obscured by this high breast density. So we've known for a long time that the sensitivity of mammography was decreased, and interestingly, when full-field digital mammography was introduced, it was especially good for premenopausal women, high-risk women, and women of high breast density. And the DEMIS trial, which was the trial that launched digital mammography, showed that the digital images were actually better and 30% more sensitive than the screen film studies for women of high breast density. So in the last year, BI-RADS has gone through another iteration, and there hasn't been a change in the assessment. They changed something minimally from numbers to letters, 1, 2, 3, 4 to A, B, C, D, but interestingly enough, radiologists no longer look at the average breast density, looking at the entire film. If there is one island of very dense breast tissue in a breast, we are now allowed to give a higher breast density, even if the remainder of the breast appears fatty. So that is the change. So given that fact, it's breast density assessment is very subjective, obviously, and it changes from time to time. So this is one of the variables that we have to take into account when we're thinking about breast density and its meaning. And I just took 5 random mammograms from reports that had been called heterogeneously dense and put them all on this slide so you could see how variable it really is. 5 women with heterogeneously dense breasts that were designated with that assessment by the radiologist reading the study. And inter-observer agreement is fairly high when you get at both ends, let's say the fatty end and the extremely dense end, but somewhere in the middle, the scattered and the heterogeneously dense breasts, there's a lot less inter-observer agreement. So again, you know, it is subjective, but we're we try to be as accurate as possible when we come about this. There are two very important things that I think we need to consider before we think about the risk associated with breast density. And when we talk about risk, it's very, very important that you understand the difference between absolute risk and relative risk. Absolute risk is really your baseline risk, the baseline risk of something happening over some period of time to an individual. So using this as an example, the average risk of developing breast cancer in the United States over a woman's lifetime is now 12.7%. So we know 87.3% of women do not get breast cancer. Now let's take that and determine what a relative risk is. Relative risk is the percent increase or decrease over your baseline risk. So a woman who has been on progesterone and estrogen hormone replacement therapy for over 15 years, we know that they have an 83% chance of developing breast cancer, very high. In order to know what their relative risk is, you would take that 12.7% baseline risk, multiply it by 0.83, and you have a 10.5% increase over the baseline. So instead of having a 12.7% risk, that woman who's been on HRT for over 15 years actually has a 23.2% risk. She's at high risk. And we define high risk by anyone who is at 20% lifetime risk or greater. So I hope that clears up a little bit about absolute and relative risk, because it's very important when they're not all the same. And if you read documents, you have to understand exactly what they're referring to, because it can seem that the risk is exceedingly high when in fact it's not. So literature on breast density really kind of opened up in 1995 in the Journal of the National Cancer Institute. There were two sentinel articles addressing breast density and cancer risk. And the first one by Dr. Boyd in Sunnybrook in Toronto, Canada, described mammographic features in breast cancer risk from the Canadian National Breast Screening Study. Dr. Boyd was actually the first to apply a computer-assisted measurement to look at the amount of breast parenchyma, or the percent breast density, on a mammogram. And he determined in his study that it was a 5 to 6 time relative risk for women of high breast density. The second article published that year by Celia Byrne showed mammographic features and breast cancer risk as well, but she took into account the variables of time, age, and menopausal status. What she identified for quite a large population of women was that the risk was higher in women of highest breast density, and it was increased beyond 10 years of the study. And this was independent of age, menopausal status. She found that that risk did not change in time for these women over the period of the study and 10 years after. So breast density has been established as a general marker for increased risk. Dr. Harvey down at University of Virginia looked at 12 different published studies. Now, one thing we're going to talk about a little later is how do we measure the breast density. We'll get into that. But these 12 studies were quantitative assessments of breast density, and she showed that there was increased risk with every study, and even after up to 10 years, and that was the Celia Byrne study. The change in breast density can change risk. So although changes may not be dramatic, the baseline density was as important as the current density. We do know that we're able to manipulate breast density, and in some women there may be a connection with that manipulation of the breast density and changes in their risk. And we'll talk about that a little bit more too. Valerie McCormick and Isabel dos Santos Silva published a huge meta-analysis looking at over 14,000 cases, 226,000 non-cases, evaluating 42 published articles. And were able to again establish that high breast density, women with high breast density definitely developed more breast cancers, and they adjusted again for age and ethnicity. This particular study did not look at BMI, which is a little bit of a problem because we know that BMI is also very instrumental and needs to be adjusted for. And just to show you their data, although this is, a very busy slide, but I just wanted to show you, if you look at increasing breast density coming down and increasing relative risk going to the right, you can see how these little black dots kind of move in that direction. As the breast density increases, that relative risk also increases. So in conclusion, the increased parenchymal breast density is strongly associated with breast cancer risk, but age and some genetic factors are definitely stronger. When we look at the absolute risk, it is a factor of approximately 1.2 to 2.1% above baseline. So although the relative risk would suggest higher, 4 to 5 times, that's relative, the absolute risk is still real and a factor of 1.2 to 2.1. So then many questions arise from this data. Is it a general marker for risk? Is there a significance to the timing? Because some people say it's important at the time it's measured, and others say it doesn't matter when you measure it. Although all young women have dense breasts, we don't want to say that everyone with dense breasts is of the same risk, because breast density generally changes with time. So it is an age-related phenomenon, and we'll show that as we move through our slides here. There's some data about whether it's specific to a location and development of cancer. Does the histology change as the density changes? Good question. And if we change the density, can we change a woman's risk, thereby possibly presenting some cancers? Good questions. So here's our breast again, and we have this little line drawing of the milk ducts throughout the breast, and I've done a very crude little drawing of a tube, and now I'm taking a little cross section of that tube to show you this otherwise much nicer image that was published in Frontiers Bioscience, looking at the cells inside the breast and exactly what their functions are. So if you look at the circle on the left, that's actually a cross-section through the milk duct. And what you're looking at are the red, oval, kind of myoepithelial cells. They're muscle cells that keep the duct round. And the little blocks on the inside are those epithelial cells that we talked about on the first slide, being the glandular tissue of the breast, that ductal epithelium, very important. Okay. Outside of that duct, as you can see in the second image, those pink kind of elongated cells are fibroblasts. And it turns out those fibroblasts also have a very important job in breast health and breast disease. And so it's a combination of these two, the glandular tissue and the fibroblasts in that white tissue inside the breast, that is determining breast health and breast disease. So we're going to talk about a few of these determinants. There are intrinsic and extrinsic factors. Intrinsically, genetics, hormones, very important, both serum blood levels and in the local milieu of the breast. And then extrinsic effects, hormone therapy, diet, environment, and others. So Dr. Boyd, who's done a lot of work on breast density, did a great study looking at identical twins. And by looking at Australian and North American twin pairs, he was able to determine that 60 to 67% of breast density was related to genetics. So the other third he wrote was related to parity, or the number of children a person has, age, menopause, family history, and BMI. Breast density genes were identified in this wonderful study performed by Vashon at Mayo Clinic, also including data from the F. Lee Moffitt Cancer Center in Florida. 89 families in a Minnesota multi-generational study were studied, and they identified a region on chromosome 8 containing 45 genes that was linked to a prolactin receptor. Now, prolactin is the hormone that is circulating when you are lactating. So that prolactin is something that's very important to generate milk in the breast. And prolactin, therefore, is very important to proliferation or growth of those ductal cells, and has also been linked to breast density in postmenopausal women. Turns out that postmenopausal women with high prolactin levels have increased breast density. Now, take a look at a small area here of the breast, very dense, very large effects of hormones. Estrogen and progesterone modulate the amount of water, the amount of tissue volume, and the amount of cellular proliferation that occurs in the breast. And when we go through menstrual cycle changes, particularly the follicular phase and luteal phase of the menstrual cycle, we have increased and decreased breast density depending on the amount of hormones that are circulating, but this is not a uniform effect for all women. So this is an ovulation cycle, and you can see this first peak here where the luteinizing hormone peaks is where ovulation occurs, and the second peak in the second half of the cycle is right before menses occurs. And there are definitely changes, particularly in the second half of the cycle, that increase breast density. It increases water retention in the breast, and that's why the breasts are tender in the premenstrual phase. It's also why we don't like to do any breast imaging in that premenstrual phase, because it doesn't feel very good. In perimenopausal women, there are actually higher pre-ovulatory estradiol levels than there are at other times in your life. And during the menopausal time, you're going through a period of apoptosis or cellular demise and involution of glandular tissue. And I just wanted to show this patient, the image, same patient, image on the left is the patient during lactation, and the image on the right is her normal breast density. So prolactin having a huge effect on breast density. Now, talking about changes in breast density with age, perimenopausal changes, again, we said higher estradiol levels, increasing number of breast cysts. Of course, we know there's disruption to the menstrual cycle. And it is followed by a progressive decrease in breast density in most women. So women in their 20s, 65% of women in their 20s have greater than 50% breast density. In your 40s, about 50-50, about 50% have high breast density. In postmenopausal women, about 30% have greater than 50% breast density. So that would be postmenopausal women, about 30% have density in the heterogeneously dense to extremely dense region. Given that, there is also about 34% that have completely fatty breasts, which means the rest are in between, right? So the involution of the breast tissue usually occurs in the outer parts of the breast peripherally, and we get progressive radiolucent changes on the mammogram, which means radiolucent meaning we're having more fatty replacement, it's getting darker, and the whiteness is disappearing. And this is a nice graph that shows 20s, 40s, 70s fatty replaced versus dense, and how these things do change with age. This is also interesting because if you look at the incidence of breast cancer, the incidence of breast cancer increases with age. So over the course of a woman's life, you're looking at rate per 100,000 women, and this is on the American Cancer Society website as well. You can see this peak occurring in the late 70s, and this is basically white women and black women, solid line versus dotted line. And we have a paradox, right? We have breast cancer increasing with age, but we have breast density decreasing with age for most women. So there is somewhat of a paradox here that cannot be explained. So there have to be factors other than breast density contributing to the occurrence of breast cancer in most women, although we still have to recognize that in postmenopausal women with high breast density, that population still remains at higher risk. So let's look at some of these other relationships. We talked about hormone replacement therapy, nulliparity or never having children, a late age of first birth, and increased alcohol intake, excessive alcohol intake. Those are related to increased breast density. Increasing age, postmenopausal status, and increasing BMI are all related to decreased breast density. Other factors include diet, particularly saturated fats, milk, butter, beef, things like that. Soy products, they all increase breast density. Omega-3 fatty acids will lower your breast density, as will consumption of the carotenoids, carrots, pumpkins, those nice orange foods, they lower your risk. Vitamin D3 will also lower risk. Interesting study done on Mediterranean diet. Women who were placed on a Mediterranean diet of whole grains and legumes, vegetables, fish, olive oil. Olive oil seems to be very important. Exhibited a significant, greater than 40% decrease in their endogenous estrogen levels relative to a control group. So that's interesting because we know that estrogen can increase the amount of breast density we have. So perhaps we could decrease breast density by a Mediterranean diet. You know, lots of studies being done on all of these things. Again, genetics has a big impact. Race and ethnicity. It varies, but in general, the women from Asian countries tend to have the greatest breast density. Most of the work being done right now with whole breast ultrasound screening is being done in Asia, and that is because the women there have greater breast density. Benign breast disease, if you have had multiple breast biopsies in the past, you have an increased risk. I'm going to quickly go through a couple of these studies. These were two studies that were performed looking specifically at the location of breast tissue in the breast to see if cancers happened where the breast tissue was densest. And they went through these beautiful little scatter plots and looked at, you know, exactly where the breast tissue was. But there's a real problem here, and that's because breast tissue is not uniformly distributed throughout the breast. Another study was done here at USC in 2005 looking for a direct relationship, and they determined that DCIS in these women did arise in the quadrant of greatest density. But truthfully, if we really look at the distribution of breast parenchyma throughout the breast, it seems that this is more of a general marker than it is specific to the location. And there have been subsequent studies that have proven that. So just to walk you through this a little bit, if you look at the average breast density, and this breast actually has breast parenchyma that's fairly well evenly distributed throughout the breast. We have the risk is the same for in this study for these women, no correlation with the location of cancer. And really, it correlates more with the amount of breast density or amount of breast tissue present more than the location. If you look at a 2D assessment of volume of tissue, we're realizing that can't possibly be a good estimation. Breasts are not a 2D object, right? And we do mammograms and we try to make them 2D, but they're not 2D. Breasts are 3D. And so we need a way to look at the volume of the tissue. Most of the studies that I've discussed with you so far have been done looking at a measurement tool, Cumulus, which was developed in Toronto, and it looked at 2D measurements, and it's this threshold measurement where the breast tissue, the densest tissue was outlined, and the breast parenchymal density was determined. And Dr. Boyd was the first to do this, and it was a step in the right direction, but as we looked at the data, it became apparent to us as radiologists that we needed a more volumetric way. First of all, measuring whiteness and blackness on a film doesn't equate to the amount of tissue present. Any of you, if you're photographers, you would know that you could have an overexposed film or an underexposed film. So film blackness, film whiteness is not really breast density. And positioning really affects the amount of breast you can get on a film. This is an example of overexposed, underexposed, okay? So if you were to do that thresholding method on this breast, on the left image, you may suggest that there's a lot more tissue than on the right image. This is an interesting case. This was a woman who had both of these CC views done, same day, same mammogram. The technologist did the one on the left to have the nipple in profile because it's a better representation of the ductal structures behind the nipple. But you can see if you put either of these through the test, the one on the left would look like it had a lot more breast tissue. The one on the right would have percentage-wise much less because we've included more of the fatty tissue. So percentage-wise it would look much less. And Dr. Kopens really shined a light on this in 2008 when he said, really, if we're going to measure breast density, we better include all of those variables that are included in an X-ray beam, because the energy of the beam, the length of the exposure, how thick the breast is, how well it's compressed, all of those things are going to matter. When you look at a breast, it's not square, right? It has a shape to it. So we can't measure what's at the chest wall the same as we measure what's closest to the nipple, because the breast is not the same thickness. So we had to come up with ways to measure that took this into account. And just as a very practical exercise, he presented this. If you look at this as a Rubik's Cube, say, and you're looking at it from above, and you take 3 blocks that are red and you put them where those shaded blocks are, and you look at it from above, it looks like 1/3 of your breast is red or dense. But if you take those same 3 blocks and you put them in a stack, it's only 1/9, right? So we had to come up with a better way. It's like looking at the outside of this breast. It's kind of like looking at the outside of a forest. You have no clue that there's a meadow on the other side of the trees, right? Or because I love food, I like to think of this is not the same as this. Okay, so now we've moved forward and we're moving on to volumetric methods, and I can say that with full field digital mammography and all the DICOM data that's available, we can measure the parenchymal density and the amount of glandular tissue that's present. We're including all of those properties of the X-ray beam in order to be able to tell us exactly how much tissue is in the breast. And the only complicating factors that still exist now are positioning, menstrual cycles, and the administration of hormone replacement therapy. If we know those things, we can make some assumptions, but yet again, they're still variables. And this just is from a study that I was working on that shows actually the breast volume. This is how it prints out. It has the patient's name, right CC. These are all the views that are printed. These are the target and filter materials, the half value layer, the compression force. Everything is in this chart. So we said we were going to talk about how we change breast density, so let's talk about that. The Women's Health Initiative was a very important study that was started in 1991, and it looked at the most common causes of death, disability, and impaired quality of life in postmenopausal women. It was conducted at 40 institutions nationwide, and part of that study looked at hormone replacement therapy. The women who received estrogen and progesterone versus placebo were diagnosed with more cancers to the point that they actually terminated the study to get the women off the combined hormone therapy. There was another part of that study, another small part of that study that dealt with breast density. And what they determined was that in the women who had the estrogen and progesterone, they had an increased breast density. They took all the variables into consideration, but those women had an increase in breast density after 1 year of therapy. Which takes us to the next thought. If estrogen and progesterone are going to increase breast density, is it possible we could shut them off and decrease breast density? And we already know that that is possible. Women who are being treated who have had breast cancer are also treated with selective estrogen receptor modulators, SERMs, one of the most popular of which is tamoxifen, which reduces the risk of contralateral breast cancer in women, both invasive and in situ cancers. And if they're treated for 2 to 5 years, they have a durable benefit that lasts 15 years. Women who are very high risk, and for the contralateral breast in women with cancer, if they are treated for 5 to 8 years of therapy, they have a reduced risk of up to 7 to 12 years. And tamoxifen reduces breast density. And this is a study that was published by Dr. Harvey, and you can see on the left, this is pre-therapy, and on the right is post-tamoxifen therapy. And this is another patient that actually is one of our patients on the left, pre-therapy, right, post-therapy. And this is not one of the more dramatic of those cases. This is, what we see routinely. This is the patient who had prolactin effect. This is the woman who had the high breast density and low breast density. Similar effects, however, are seen in women who have had chemotherapy. I just wanted to say one thing about raloxifene. Similar effect to tamoxifen, about 76% effectiveness with much less toxicity in postmenopausal women, but it also has less effect on breast tissue density. And the IBIS study also showed decreased cancers in the tamoxifen group. They also demonstrated decreased breast cancers, decreased breast density. Now I'm going to take you on a little walk here, looking at something very interesting. This is breast tissue. It's mammary breast tissue. And the little areas that are outlined in red are the glandular elements, and the area that's outside of that are the connective tissue, or what we're going to refer to as the stroma. So there are actually microdissection techniques where they can dissect out those little mammary areas and study them separately from the stroma. Aromatase immunoreactivity is increased in dense breast tissue. Now, aromatase is the hormone that converts circulating androgens, hormones, and turns them into estrogens. So aromatase inhibitors are those other drugs like anastrozole, exemestane, letrozole that are given to women who are high risk or being treated for ER-positive breast cancers to shut off the aromatase. The aromatase is increased in dense breast tissue. Very interesting, right? So you would assume that you're going to have higher levels of aromatase, you're going to have enhanced estrogen synthesis, and you're going to have a greater lifetime exposure to estrogen in dense breast tissue. Now, let's not look at that. Let's look at the fibroblasts, or the stromal cells. There are carcinoma-associated fibroblasts, or tumor-associated fibroblasts. Some people call them TAFs instead of CAFs, that can actually promote the conversion of epithelial cells to cancer cells. And they know this because they've separated these two groups of tissue, and they've taken the tissue from normal cells and placed it with epithelial cells that are starting to turn into cancers, and it actually stops it or slows it, which is really amazing. If you look at these tumor cells, these little pink cells that have busted through this wall, it turns out there's conversations happening both in the duct and outside the duct among these cells that's actually allowing a tumor to break through. And if we have higher concentrations of these chemicals in the stroma of dense breast tissue, this could explain why these cancers are occurring. A couple other things just want to touch on very quickly. Insulin-like growth factor is influential in breast development. It's peaking in puberty, and this IGF-BP3 is binding protein, and that's responsible for involution. So as we age, binding protein goes up, Post-lactation, binding protein goes up, IGF-1 goes down. There are higher levels of IGF-1 in women with dense breast tissue. Interesting, right? Because that means breast developing, even after it shouldn't be developing. And the binding protein happens to be associated with women with lower mammographic density in the premenopausal but not the postmenopausal group. So it's very interesting. We're not quite sure if this is susceptible tissue or if it's an interaction between those two components, stromal and epithelial. And we also know, interestingly enough, that tamoxifen also decreases that IGF-1, which is that proliferative effect. A few people have also looked at the fat. We look at the fibroglandular tissue and we look at the fat. And the fat is a source of local estrogen in the breast. And there are other cytokines, leptin and adiponectin. Not important that we know the names, but one thing you need to know is that they're relative to fat only, and they either promote cell growth or reduce cell growth, very similar to the IGF-1 and the binding protein. So these are also areas that are being looked at. Leptin, because it is such a strong promoter of proliferation of the epithelial cells, has a possible connection to triple-negative cancers. So more study to come. So we know that parenchymal breast density is a surrogate for breast cancer risk. It's an independent marker of increased risk in either breast. And unlike most other risk factors, it can be influenced. So most of this we've reviewed already. We have high breast density in 30% of postmenopausal women. And most of what we know so far is that postmenopausal women with the highest breast density are probably at the greatest risk when you compare them to their cohort with the lowest breast density. So those two groups probably have the greatest difference in risk. This is current research that's going on. Cannot wait to see this published. Isabel dos Santos Silva, who we quoted earlier in this talk, is publishing this. She's looking at mammographic density and looking at personalized breast cancer screening and clinical management, something that we really need to wrap our brains around. One of the things I do want to mention, though, even as we talk about changing screening intervals, adding supplemental screening, and changes in the way we look at treating women with high breast density, is remembering that there is a very large threat on the horizon for screening mammography. And there are to be new U.S. Preventive Services Task Force recommendations due out this year. And for women under 50, I am very concerned that screening may be in jeopardy. 23% of all breast cancers occur in women under the age of 50, and that 40 to 50 age group is not without risk. So just, you know, as we talk about breast density, we have some really fundamental things for women that we need to maintain. Excuse me, and screening mammography is very important. So we have women learning about their breast density, and kind of the question is now what? What do we do? And this is a copy of our law. This is the law in the state of Pennsylvania, which Pat and Pennsylvania Breast Cancer Coalition were very helpful in promoting and advocating for. Excuse me. So breast density without a risk assessment is probably not as meaningful. And we understand now that we have to really look comprehensively at a woman's risk, including her breast density. So women with first-degree relatives testing positive for BRCA or other genetic mutations, high risk. Patients with prior mantle radiation to the chest for lymphoma, high risk. And patients with prior high-risk histologies showing atypia, atypical ductal or lobular hyperplasia, or LCIS, probably high risk, and need a risk assessment. So it's pretty simple for women with a lifetime risk over 20%. We have supplemental MRI screening. It's covered by insurance. It's been proven. We know we increase early detection in these women. Most of these women who are high risk, over 20% lifetime, also have very dense breasts, coincidentally. It's always a struggle to say it doesn't replace the mammogram. It is a complementary study. This is just some interesting data looking at mammographic density and the risk of cancer recurrence after breast-conserving surgery, and these are women who have had breast surgery. All patients, if you look at breast cancer recurrence years after diagnosis, if you have radiation therapy, it stays pretty low. You start getting more recurrences without radiation therapy, and interestingly enough, the women who have had radiation therapy also have a significant decrease in their breast density. So what about women who are high risk but claustrophobic? Ultrasound is available, and it is quite good. For years, we've depended on handheld ultrasound, but we now have automated breast ultrasound. It has been proven to show additional cancers in high-risk women, but unfortunately, it has a very high biopsy rate. At this point in time, we have no data to support widespread use of the technology, and there certainly is no uniform support for reimbursement of this technology for women. And this is just a couple of images showing you the difference between the handheld, and you can see on the left, the woman holding that transducer doing the breast ultrasound. You kind of have to depend on the person doing the study to make sure you cover every square millimeter of that breast and also get everything covered behind the nipple, which is not an easy area to scan. On the right, you can see the automated whole breast ultrasound. 3 separate compressions with this little paddle are performed and the entire breast is covered. So there have been several good studies published so far looking at women, first in Connecticut because they had the first breast density law. And they took all comers. Only 9.3% were high risk. But 20% required short-term follow-up, which is a lot of women to follow up. When you look at the recall rate for mammography, it's only 9 to 11%. 5% of their patients were BI-RADS4, which means they were recommended for biopsy. And only 3 cancers were identified. So the positive predictive value, which is something that we rely very heavily on to know whether or not what we're doing is good for patients. If I have a positive predictive value of 6.5, that's very low. If I make a recommendation based on a mammogram and an ultrasound for a biopsy, it should be somewhere between 25 and 40%. So 6.5 is very low. And Dr. Berg also published an excellent article in JAMA. Multiple institutions contributed to this, and they identified 3 to 4 additional cancers per 1,000 women screened. They looked only at women of high risk, elevated risk, not necessarily high risk. Their positive predictive value was 11%. And if you looked at ultrasound only, it was 9%. So a little bit better than the first Connecticut experience, but not terrific, because positive predictive value for mammography, they're 30 to 40%. Another presentation was made at the San Antonio Breast Cancer Symposium last year, a 4-year retrospective of the Connecticut experience, and truthfully over time the PPV did increase. It increased over the last 4 years from 8 to 16%. And another study was presented also at San Antonio from NYU with a PPV of 2.7, not so good. Which brings us to tomosynthesis. Tomosynthesis is a 3D mammogram. Originally, when we went to full-field digital mammography, I said we had a 30% improvement in imaging dense breasts. Tomosynthesis has enhanced the identification of some cancers and has significantly decreased the recall rates. We also have less extra views. I have a couple of images here just to show you this is a routine mammogram, and on this slice through the breast, the 3D mammogram, you can see the spiculated mass where it's really hidden in the breast tissue here. You'd never have an idea that anything like that was happening. And this is the craniocaudal view, same patient. You might say, well, there's a little round thing here, perhaps that's it, but you don't understand that there is this little tumor with this spiculation here in the breast. So 3D obviously is going to be helpful in dense breast tissue, but may not be the entire solution. What's great about it is that the callback rate after screening has decreased 30%. And women will be very happy about that. No one likes being called back after mammograms. So decreasing that by 30% is terrific. We'll see how it contributes to the positive predictive value. So as far as risk benefit of supplemental screening, first of all, we have consistency and accuracy of BI-RADS assessments of breast density. Again, highly subjective, although fairly uniform and pretty good kappa value when we look at inter-observer variability. But when we look at offering supplemental screening to women, we really need to know what their risk factors are, have a much more comprehensive idea of that. Doing this does not prevent cancer, although we may be adding to early detection for many women. So we really want to move in that direction. For many women who are identified at high risk, chemoprophylactic measures seem to be not attractive. Certainly at our risk assessment clinic, we know that when we identify women with high risk and are of increased breast density, if we tell them they need to take tamoxifen and they're premenopausal, it's not terribly attractive. So there are many things we need to work on. There's lots of good work in progress. I hope that this has been a benefit for you, and I thank you very much for your attention, and be happy to take some questions now.
Thank you so much, Dr. Shetter. A wonderful, very informative presentation. We thank you very much for being here with us this evening. We do have a couple questions. First one, since it was just being discussed, comes from Alice, and she was asking for a bit of a clearer understanding of what tomosynthesis is.
Great question, Alice. I ran out of time at the end, so I was a little skimpy on that. Tomosynthesis is a mammogram. It requires compression, but it gives us a three-dimensional view of the breast. So some of you may be familiar with a CAT scan and how a CAT scan slices through the body. The tomosynthesis generates a data set so that the radiologist can review very similar slices through the breast. So what it does is it eliminates overlapping breast tissue so that we can see each slice through the breast without the distraction of the breast density kind of masking something else. So it is a 3D technique of breast imaging.
Okay, great. And is that something that is fairly common? Do you think that's something that would be available to most women at their local hospitals or mammography centers?
It's becoming more available. One of the downsides for some of the places that are available in central Pennsylvania, I know right now, and even in the Pittsburgh area, the insurance companies are not covering it. Interestingly, CMS or Medicare does cover 3D mammography, but the insurance companies so far have not. So one of the things I think we need to move on is having them follow CMS's lead. CMS rarely leads on reimbursement unless they think that there is a definitive improvement in what we have. So I think that maybe over time it will be available. So I know a lot of centers are actually having women pay an additional fee when they have their mammogram if they want 3D. When we institute 3D here in our breast center in about a month, we'll be working up to basically using it for all screening, whether we get reimbursed or not, because I am convinced that it will help us identify small cancers that could be obscured by dense breast tissue.
Well, it's encouraging that the CMS is covering it, that hopefully people will follow suit.
Let's hope.
Great. Tori asks if an ultrasound should be done in addition to mammography for women with dense breasts.
Very good question. So again, I think supplemental screening is going to depend on knowing your level of risk. And using a comprehensive approach to each individual is what we're going to need to make sure that we're not doing unnecessary biopsies and unnecessary callbacks on lots of women who don't need them. So far, the data has suggested that if you are of increased risk with dense breasts, supplemental ultrasound screening will be beneficial.
Okay. And it's quite possible that it could be that some of this is case by case as well.
Yes.
Let's see, I have a question here about your feeling on thermography breast imaging.
So I don't have experience with thermography. I have reviewed some examinations of thermography. I understand that thermography functions looking at breast physiology and has lots of false positives. So, for instance, thermography is much lower in specificity than a mammogram is. So still, as much as we dislike it, the mammogram remains our #1 test in the early diagnosis of breast cancer and is the reason we've had such a decrease in mortality with early diagnosis. Thermography identifies areas of increased blood flow, increased inflammation, and that can happen with fibrocystic disease, so fibrocystic changes in the breast. So the specificity, to my knowledge, is low.
Okay, thank you. I have a question from Amy that she asks, what resources do you recommend for patients to identify if they're at increased risk or not?
So first, I would do a really good family history. For most people, that's the best place to start. And not only look at your maternal history, but also look at your paternal history. Those cancers on your father's side are as important as those cancers on your mother's side. And for many years, women were not told that. So when we're looking at potential genetic cancers, that paternal history is every bit as important. If you start with that, you can go, Gail Model is online, and you have to be 35 years of age or older in order to use the Gail Model, not because there's an age restriction, but because it's not valid below that age. It's not like 21 and a drinking age or anything. It's just you have to be 35 for it to be valid. So it is available online. The NCI website, National Cancer Institute website, has the Gail Model available for you to check your own risk. If you determine that you are high risk or you suspect you are, then you should seek further evaluation at a risk assessment clinic and determine whether or not genetic testing is appropriate. That would be the next step.
And piggybacking right off that, Nancy asks, who specifically, which doctor that a woman sees would provide that risk assessment, and when should they have the assessment done?
So many physicians don't deal with breast cancer risk assessment. For many years, it was oncologists who dealt with risk assessment and the prescription of tamoxifen for women who are at high risk. Now, we have a risk assessment clinic here in the breast center. The family practitioners will refer to a risk assessment person. It could be a breast surgeon. It could be an oncologist. There are a number of people in the community who will do it, but I would say primary care likes to refer because you're starting to get into a more specialty-specific area. Women's health providers, I think, also would prefer to refer. They're not going to prescribe tamoxifen or even prescribe genetic testing.
Okay, good. I have a question here from Melanie. She's asking, when you are called back to have a diagnostic second mammogram, is the additional exposure detrimental, and why can't they just take extra pictures at the original mammography session?
Great question. So the extra views that are performed generally with a specific paddle that performs a specific function. So if it is an asymmetry or a mass that's suspected on the screening mammogram, then spot compression views are performed to get a better look and try to smooth out the dense breast tissue so you can see what's underneath. If there are calcifications, it requires a small paddle with a magnification technique to get a better characterization of the calcifications. If you have a mammogram, you can ask at the time of the mammogram to have someone read it. I'm not sure how that works everywhere, but I only know how that works in my institution. And we have women who like to be in and out in a hurry. So they come in and they'll get their mammogram and they're out the door in 10 minutes and they just want to get on with the rest of their day. And then we have a number of women who prefer to wait, and they do get the results. And if we find something that's abnormal at that point in time, then they do get their extra views at the same time.
Thank you. Barbara is asking, after her breast cancer, she took 5 years of tamoxifen and 5 years after that letrozole, and she still has heterogeneously dense breasts, and she's wondering if that means her breasts were even more dense prior to those interventions.
Oh, I would say more than likely, Barbara. Absolutely.
Oh, here's a really good question from Michelle. She's asking if there's a difference in breast density between nursing and non-nursing mothers, even later on after they've had their kids.
Well, let's say that we know that breastfeeding is something that's good for the breast. So if you have breastfed and you breastfed multiple children, there's a protective effect. It turns out that women who have children young tend to have fattier breasts later. Turns out women who have breastfed multiple children young have fattier breasts later. Women who have never had children or have had their children very late, even if they breastfeed, don't have the same decrease in breast density after their children that women who have had their children at a younger age do. So it's kind of a combination of both the breastfeeding and the age at which you had your children.
And when you say a woman who had their children young, does that mean like under 30? What would you classify as young?
I would say, well, we only, the women who are classified as advanced maternal age is over 35. But if you have children in your 20s versus children in your 30s or even later, that's a pretty good dividing line.
Okay, great.
Or at least started having children in your 20s.
Yeah. Amy has a question from an insurance standpoint. If they consider them screening ultrasounds, if they will classify something as a screening ultrasound, I assume to help get things covered easier.
So there is a new code for screening ultrasound, and that's something else CMS came up with, which we're very happy that they did. And my guess is that if there is an appropriate clinical indication, and I don't think breast density will be it, but breast density in addition to difficult breast exam, increased risk, that the insurance companies will likely be covering that.
Okay.
I haven't heard of any denials in that area. The denials that I've heard of so far have been for the 3D mammography or the tomosynthesis.
Okay. Well, and we're hoping that they'll change their tune about that soon. Luann is asking about women who are postmenopausal, if an MRI is better or more reliable, especially in the highest density category.
So MRI is reliable. It's got the highest sensitivity and specificity in the identification of breast disease for women who are at 20% lifetime risk or greater. So it is not recommended in women who have less than a 20% lifetime risk. So just having increased breast density is not a good indication for an MRI. Hoping that postmenopausal with higher breast density and perhaps some risk factors, whole breast ultrasound should be used for those women. At least that would be my intention. I think whole breast screening ultrasound to complement the mammogram will be the way to go for those women.
And that actually ties perfectly into another question and maybe even answered it, so I'm sorry if it's repetitive. But one woman has given us a bit of her background and said that she has had 2 paternal aunts with breast cancer as well as her brother, but the brother had a negative genetic testing, and she's wondering if an MRI should be recommended. She's 46.
She should see someone and have her risk, a full risk assessment performed, I would say.
And luckily we got a message through the questions box from Anu that the Gale model is very easy to do. She said she just did it. It's limited a bit in its ethnicity, but it was a great resource, and she really appreciated you sharing that with everyone.
Great, I'm so happy.
So I see we have questions are slowing down here. If anyone wants to get in your last-minute questions, please do. But in the meantime, I really do want to express our gratitude to Dr. Shetter for spending this evening with us, for putting together this wonderful presentation. We work with the Hershey Medical Center closely, and we're happy to be partners with them. And this has really been wonderful. Please do, if you want to share this presentation with people you know, or if you just want to refer back to it at a later date, because I know it is a lot in a short period of time, we will have it on our website within a week. It should be even less than a week. So that will be available for viewing just really whenever. You can email it to people if anyone you think would be interested in this information. So I don't see any other questions coming in, just some thanks, words of thanks from people who have been on the webinar, and we do appreciate that. So with that, Dr. Shetter, we thank you for working with us on this, and we will put the information up online for anyone to view at a later date.
Terrific. It's been my pleasure. Thanks so much, Erica.
Well, everyone, have a great evening. Thank you for participating in the webinar.